who in this audience would be willing to forego tests, routine preventive medical tests, in order to save costs as a matter of national policy?
Can I talk about this? This is a critical question.
Test?
Any test. Let me raise it. Let me speak to this for a second, because it's very important.
I mean, I'm someone whose cancer was detected not symptomatic, just through a routine mammogram, even though it was not recommended that I have such testing.
Right. We talk about this as if it's always the providers who are saying, you got to get that test. You forget how many men and women, when they heard about the restrictions that the new guidelines on mammography and PSA said, what, are you kidding? I want to know. But that gets me to another point, which I think is really, really critical. When I was in medical school, which is a long time ago, the doctor who we would all admire was the doctor who made the rare diagnosis that nobody else could figure out. And that doctor made the rare diagnosis because he often ordered the test that nobody else could have thought about. And as a consequence, as I was a house staff officer, my senior house staff officer talked about a spinal tap and said, if you just think it, do it, which was the mantra and kind of the culture. We're here to save lives, and if we save one life, it's worth it no matter what the cost. Now that is totally turned upside down. Now, if we do 99 tests to save that 100th patient, we're told that that's profligate, and that there's something that's grossly inefficient, and how dare we do that? And you know what? We're teaching our medical students now that it is profligate. But the question comes down to, what is a human life worth? And that's what is absent from this debate.
You just made the point far better than I made it about this whole question of how we're going to deal with the issue of access. That's your point. And if somebody comes to me and says there's a 1 in 100 chance that something might be wrong and we'll give you the test, on a social and on a broad social basis, it probably shouldn't be done, but I'll tell you, if it's me, I want it done, which is your point precisely, and it goes exactly the questions I was trying to raise before, and nobody in our society wants to face.
But you know, I think
it's good thing you weren't at the Zeke Emanuel panel.
Right. Well, no, but that's where I was actually going to go, which is this is an extremely hard question. But rather than framing it in terms of what tests you would forego yourself, you could also ask, how many of you would be willing to have your taxes be $1,000 a year higher for a whole bunch of tests that lots of people get, that the medical evidence suggests that even on an individualized basis, that for them, it doesn't make sense to do. And that's fine. You would support it. The problem is most of the population would say, I don't want to support those tests for other people. So therein lies the challenge, which is, and it might lead to a perspective, by the way, which I think you could do of, it's consistent with the value-based insurance design, where basically if the test for as disaggregated a slice of the population as possible seems to make sense for you, fine. If it doesn't, you can still, of course, do it, but your copayment is going to be a bit higher. And that way, people who want to get the test can do it. Now, it fortunately brings in a little bit of the resource question, but we're going to be, as a society, facing that anyway. And so you don't avoid it by just propagating the system we have where we're paying for pretty much anything. But I think that the right approach is what I just mentioned, which is to go as disaggregated as possible. And if you still want to do it, even though the evidence suggests that as disaggregated as possible, it doesn't seem to be indicated, you're going to have to pay more for it.
But
so that we just make
Bob
sure.
Bob is starting to twitch over there.
Yeah,
no, I'm just saying that's access by affordability. You also better be careful about what you wish for. Peter said before that now we're going to have financial incentives instead of different set of incentives, right? In bundling and capitation. Yeah, that's what you said.
Well, we already have financial incentives.
I know. It's a different set. No, it's a different.
Bob, we've actually recorded it, so we can go back and see exactly what he said.
It's a different set of incentives. Now it is to be more efficient, to provide value.
Right.
Okay. But there may also be incentives that you don't like, which is in a capitation bundling system. Maybe the incentive is not to provide the best possible care, but rather to provide the least care that you can relative to the dollars you're going to get. And the question is, how do you deal with that? Which is also not a very simple issue, I think. The larger point is simply this thing is massively complex, and we have none of the processes necessary, in my opinion, to make sound judgments for our society.
Now, Andrea's question relates to tests that she knows about, mammography, PSAs. But for every one of those tests she knows about that Peter says you could ask for that test and then you could pay more, There are lots more tests you don't know about that your doctor knows about. But when your doctor is in a healthcare system, as we're moving toward, and I fully support, we're an accountable care organization, we're prepared to manage risk, we understand that fee-for-service is dead, I believe, over the long term. The country can't afford it. But there will be, as a consequence, tests that the doctor will not do because the doctor knows the chance is only 1 in 100 and he can't support it. And in fact, what happens at the end of the year now is doctors are given a profile of what their resource utilization is. And if their resource utilization is outside the norm of what for that practice or for patients with that diagnostic group, that doctor's not going to get the same bonus as a doctor who is more resource efficient in what they do.
But here's the problem, though, Ken. What if it's better than the norm?
What do you mean better?
Well, you said if the resource
utilization... Oh, yeah, he's going to get a bigger bonus if he's better than norm.
Therefore, it seems to be my incentive is to give a little patient as little care
But
as
the
possible.
good news is, and thanks to Peter and his team, when we drew up the ACA and we talked about the ACO, there are quality metrics that you got to meet. And the difference between HMOs in the past and what we're moving toward, hopefully, is that we'll have some rigorous quality measures, you know, around how you manage diabetes, how you manage hypertension, how you manage congestive heart failure, you know. But I think that's good, and that's going to help